Anyway, let's get going. So we actually don't we don't have too much more to go, really. So let me share my screen again. Okay, so we'll pick up back on what we do for rehab. So we actually can start if we are seeing now, obviously, if we're seeing somebody that has a traumatic amputation, we're not going to be able to see them post-op because we can't predict that amputation is going to happen. We can't look in a crystal ball and say, get ready, you're going to have an amputation next week. But if somebody is having an amputation for vascular reasons like diabetes, or maybe if it's because of cancer or something like that, there are things that we can do operatively to help them get ready for surgery, and to help them get ready to know what to expect when they wake up after surgery. Okay, so we can go ahead and we can already do an eval of their functional independence in their home. We'd probably go have somebody do this as home health, because this is where they need to be functional in the first place. Teach them protection of the remaining extremities, because if they're vascular patients, then remember, they're going to be at super duper high risk of losing the other extremity in the next 5 years anyway. So we need to teach them, like, okay, yes, you're getting this limb amputated soon, but it's a chance, because of your vascular disease, you could lose the other limb one day. And it's our job, we do need to educate them on that. And if the PT didn't tell them that during the eval, well, then that's your job as the PTA to let them know that, yes, it is a possibility, and there are statistics that show that, but protection of the remaining limb is really important. So making sure that they're wearing nice supportive shoes that maybe are diabetic approved shoes that are softer. Making sure, and this may sound funny to you, but making sure when they put their socks on every day, that their socks are put on nice and in their right position and straight, and no wrinkles are in them. Because if their socks have a wrinkle in them and then they put them in their shoe, they may get a pressure sore. And what do we know about people with diabetes and their sensation? A lot of times they start losing sensation distally. So if they can't feel very good on their foot, and then they've got a wrinkle in their sock, they get a pressure sore. Now they've got a wound. Well, they don't see that wound on the bottom of their foot for 2 or 3 days. Well, now that wound is infected. When now they go to wound care, it's too late. They lose their foot, all because of a wrinkle in their sock. And I know that sounds like I'm making that up, but it's a true story. I've seen a patient and it all came from a wrinkle in his sock. Now, that is a outlier. It usually is something like they're barefooted in their house, and they step on something and get like a little splinter in their foot, on the bottom of their foot, or they get a little pebble in their shoe and they walk around with the pebble in their shoe all day and they can't feel it. So, and it gives them a wound, and then that leads to an infection and eventually an amputation. So that's a lot of times how it happens. So that's what we need to tell them to, foot care, making sure their socks are on straight. They have nice, soft, supportive shoes, that they check their shoes for, splinters or pebbles all the time. They don't need to walk around barefooted inside or especially outside because of that risk of getting something in their shoe, and because they can't feel things. And we need to go ahead and make sure they have a referral to a prosthetist before they have surgery, because the process it's good for them to talk to the prosthetist before the surgery if they have that opportunity, because then they can let them know, the prosthetist can see what they look like, can kind of get a glimpse as to like their house, what they need, what they're going to have to overcome, and things like that. But We usually don't get a chance to do pre-op education and training before an amputation. It's almost exclusively post-op, okay? So that's what we're going to focus on. So on post-op, obviously you would think we're going to do a lot of strengthening, and we are, and we strengthen like crazy. We strengthen every single muscle in the body, more than you would think. Then we do a lot of prosthetic management, as far as learning how to manage the prosthetic, taking it off, putting it on by yourself. There's different layers that go on with the prosthetic. You don't just stick your leg in a piece in the plastic shell and walk away. There's lots of layers you have to put on before you lock yourself in. There's a specific wearing schedule you have to go by when you first get it, just like a new orthotic. And then they have to learn how to do lots of skin inspections every single day of their residual limb. And that's a lifelong commitment they have to do. So we'll start talking about all those things now. Okay, so post-op, but still before they get their prosthesis. So they're not getting their prosthesis for a little while after they get their amputation. They still have a lot of recovery to do, and they've got to do a lot. Their wound has to heal, but they've got a lot of strengthening to do before they get ready to handle a prosthetic limb. Because a prosthetic limb is made out of plastic and metal, and it's made out of usually titaniums or aluminum, and those are very, very, very light, and the plastic is not very heavy either, but it is adding a few extra weight. It's pounds on the end of your residual limb. It may or may not be as heavy as your original limb. It just depends on how big your prosthetic limb is and how high up your amputation is. But we start with these people day one post-op. So they have their surgery, and then the next day we wheel them down to the gym, get them out of their bed. Try not to do any therapy in bed because they need to get out of bed. We're going to be strengthening their upper extremities as much as we can, their remaining lower extremity. Certain muscles of their residual limb we will focus on depending on if it was a transtibial or a transfemoral, and we'll talk about those later. And really, really, really important for amputees are core muscles. Even if they say they have a strong core, their core is not going to be ready for walking with just one leg and a prosthetic leg. It's not going to be ready for that. You have to train your body. You almost have to train your brain and your core to work differently now. It's really, really weird. So what kind of things do we do? Sitting over a ball or a bolster to work on your core strength. Doing things in quadruped. If they still have one leg, if they still have one knee left, they can get in quadruped to do a lot of core strengthening. They can do alternating arms and legs like that. Tall kneeling, sure, I don't know why I put that on there. Even if they had what's called a knee disarticulation, which is where they go right through the knee joint, and so basically they remove the whole tibia and leave the end of the femur intact, then you could stand on the end of the femur and do tall kneeling. But if they have to cut the femur in any way and you're a transfemoral, you never want to stand on the end of a cut femur because it's just flat bone, and that's always going to be painful. You can do tall kneeling if they're a transtibial because they still have their own knee left. Tall kneeling exercises are really good core exercises, really good hip extensor exercises, and balance exercises, which they need a lot of. And you might as well do as much as you can before their prosthetic limb gets there, because they're going to have a hard enough time with it as it is. CAT-CAM exercises are a specific type of trunk exercise, and there's a whole packet of those. I put them on for you for Blackboard, and we'll go over those in lab too. Bridging, single leg bridging, Supermans and prone, to keep their back. We got to work on their back just as much as their abs. Scapular stabilizers. Got to keep do some aerobic activity. So if they've only got one leg left, they can do a bike with just one leg. That'll really get their heart rate going. Or really, really, really good are the arm bikes, the upper extremity bikes, because believe it or not, because your arms are closer to your heart, if you put resistance on those arm bikes, you can get a better cardiac workout than if you were doing a recumbent bike on lower resistance with two legs. That's just because of where the muscles are and what muscles are using the most oxygen. I learned that from a cardiologist one time. I don't know if he was making it up or not, but he's smarter than me, so I believed him. But like I said, I said it up here already, but I'll say it again. Core strengthening for these people is huge, because even if they had a good core to begin with, now their center of gravity for their body has changed because we've removed part of one of their legs or both of their legs. So their center of gravity for their body is now completely different. So learning to walk is going to be real different. So they've got to have a good core to be able to do that, or they're going to topple right over every time. And you can never stop working on core enough with amputees. And make that, and if you make that the biggest part of their home program, then you're successful. Okay, so what is the PT looking at during their initial eval and exam? Well, they're looking at range of motion of everything and the strength of everything that's left. And they're not just looking at the residual limb strength and range of motion, but they're looking at the arms too, because arms are going to play a part in crutch training and parallel bar strength and things like that. We're going to look at the residual limb status. So how much range of motion is left in the residual limb joints? So if it's a transtibial amputation, do they still have full knee extension? How much knee flexion do they have? How much hip flexion and extension do they have? If they're a transfemoral amputee, how much hip and knee flexion, how much hip extension and flexion do they have, and how much abduction and adduction do they have? We have to think about all those things. Because without the weight of the whole leg, muscles imbalance starts to take over. And if some muscles have been removed during the amputation surgery process, then the muscle imbalance is going to be shifted. And so the limb may start to drift one way or the other, and contractures can happen really fast, and range of motion can go down really fast. So it's real important for the PT to evaluate that at every evaluation they have, whether it's inpatient, acute, or rehab, and then acute rehab, and then outpatient, and everywhere they go. They need to have all of those things, their residual limb range of motion evaluated, and strength. Look at their functional status, look at what they can do with or without. So right now they don't have a prosthetic limb we're seeing them. So how can they transfer right now? Can they walk with a walker? They need to be able to walk with a walker, because if they can't walk with a walker, how are they ever going to walk with a prosthetic limb? So can they walk with a walker or crutches? Okay. Can they get up and down stairs with crutches? Okay. Or a step or a curve. We need to look at their phantom limb sensation. So you've heard of phantom limb pain or sensation, where people can still feel their amputated foot, and they'll say, my foot itches, even though I know my foot's not there, and I can look down and see there's no foot there. The bottom of my foot feels tickly, or I feel like I need to scratch my foot. That's called phantom limb sensation, as opposed to phantom limb pain, which is truly like a burning electrical type pain, where it feels like the limb is there and it's actually feels like a burning type pain. Usually those do go kind of fluctuate in the first year after your amputation, and then depending on how aggressive you are and how serious you take your rehab, it should stabilize in about a year and get less and less and less. Now, some people are going to keep a certain amount of phantom limb sensation or pain. They may be on certain pain meds for it, or certain, like gabapentin is a common nerve pain agent that they give amputees for nerve pain. I mean, for phantom limb pain. But sometimes it may go away completely. But it really does, if you're not very aggressive with your rehab in that first year, if you just kind of play it safe and never really if you never do any prosthetic training and you just don't do anything, then you're probably going to have a lot of phantom limb pain develop. And really similar to chronic pain like CRPS, like if you remember CRPS, complex regional pain syndrome, it's not the same thing, but it's very similar and similar reasons for getting it. And if you notice, I put down here emotional status, just like I hit this big, I thought last semester during neuro, we need to think about amputees' emotional status too, because they've just lost a limb or they've just lost one or more limbs. They can't walk anymore, and they're sitting there and they're just like, all they can think about is, I don't have a leg. How am I ever going to walk again? Or how am I ever going to learn this? That's all they can see and think right now. Nobody is going to be positive and see the light at the end of the tunnel on day one post-op. Maybe maybe they can have a good attitude, but they're deep down, they're facing some emotional trauma to this. And, you know, it's going to be different levels depending on if you were expecting it, if it was vascular, versus if you were not expecting it, versus if it was trauma. So, you know, some people may be ready for it. Some people, it's going to be a surprise about losing a limb. So we have to be ready to help people deal with that. So again, we're not mental health counselors, but we can at least talk to people on their level, let them know we treat them with respect, and that our job is to help them learn how to walk again. So if that's their worry, well, then we're the people that are there to help them fix that. We can refer them to social work or counselors on the team too, that they'll have on their team, and to try to work with them with that too. If you're working with them on an outpatient basis, there's a lot of different, I think it's called the Houston Amputee Coalition is what it's called. They do a lot of things for people of all different types of amputees, upper and lower. And it doesn't matter how long you've had your amputee or your age or what you're interested in. They have all kinds of activities for people with amputees mostly sports, but of all levels, all the way up to geriatric golf. But they do running, they do track meets and track stuff. They do soccer. They do a lot of support groups for different ages and they do caregiver support groups and spouse support groups. They do some of them that do, like, some of them they get together and do hunting expeditions with their prosthetics, and it's cool. I've seen people with double lower extremity amputees. I've seen a picture of a guy. I might have the picture saved from the lady that usually does the lecture, but an old patient of hers had bilateral transfemoral amputations, and he was still able to go deer hunting. And she showed a picture of him holding one of his kills one day after hunting. So sorry if you don't like hunting, don't call Pete on me, but that just shows you what people with amputees can do, or with amputations can do. The sky's the limit. Just because you lose a limb doesn't mean you are woe is me for life. You can do anything. When I worked at Tier Hospital, there was a spinal cord physician that I never knew it until I left here, and I was there for 4 years. He had a lower extremity amputation. I think he was a transtibial, but he wore his pants all the time, so I never knew it. And it was also another thing. He never took the elevator. He always took the stairs. And our tower was 6 floors, and his main floor was on the 5th floor. He always took the stairs. He never took the elevator, but he had a transtibial prosthetic, and I never knew it until I left. So don't let people believe that they can't do things, because they can. Other post-surgical interventions, we need to teach people to positioning to avoid contractures. So we never want to, you'll always see people, you might see people lying in their bed with their residual limb up on a pillow. Well, that's a no-no, especially if it's a transtibial, because think about it. If you have now a short tibia, which is a short lever arm, and you've got a pillow under your knee for comfort, and it's keeping your knee in flexion, well, that's just keeping your hamstring shortened. Well, because there's not much tibia left, the hamstrings are staying in a shortened position. So transtibial amputees run a big risk at getting hamstring contractures. They have to really worry about their hamstrings staying lengthened, and they have to really stretch out their hamstrings every day. Transfemoral amputees have to worry about hip flexion contractures, because they spend a lot more of their day sitting in chairs, not walking as much, and they have to use their hip flexors very, very more strongly than what we do to walk. So they're at risk for developing hip flexion contractures. And when you develop any kind of contracture as an amputee, your prosthetic is not going to fit right, and it's going to completely change your gait until the point where you won't be able to walk at all. It'll change your standing balance, it'll change your dynamic walking balance, and then it'll change your transfers. So contractures are very, very, very easy to avoid, but once they are there, they really make life hard. And remember, if it's a true contracture that can't be released with stretching or casting, the only way to get it released is with surgery. But if that's the only way to get it released, I would recommend doing it, because I've seen it done a lot, and it really does get your life back. So it's just because you have to have a tendon lengthening surgery is not a bad thing. It can help you get your mobility back.
There was a guy in my first clinical who had the femoral bilaterally,
Yeah.
and his family just kind of left him in bed and in his wheelchair, and he had to relearn how to walk because his contractures were so bad in his hip flexors.
So he probably had like no hip extension.
Yeah, nothing. Like I would try to work with him and he couldn't even stand up. They were contracted.
Oh, I've seen somebody just like that. I can only imagine. And so, I mean, and I mean, think about this, Cheney. I don't have to tell you this, but I mean, you worked with that man and you saw how hard he was struggling. Do you think that man's ever going to be able to walk again? Right?
Right. And not only that, but his emotional status was just in the gutter, and it didn't take a lot to see that either.
Exactly. He was left in a wheelchair or a bed for most of the day, and it doesn't take a long time for a contracture of any muscle to happen. So those hip flexors just tighten right up. And even if you have the best prosthetist and the best prosthetic limbs, when you get a contracture, it just changes all your alignment. And I mean, we're going to talk about energy expenditure in a minute, but I mean, the higher of an amputation you have, the more energy expenditure that you have to use to walk. So, you know, I'm sure your patient was just like felt hopeless. I mean, and that's terrible, because he obviously fell through the cracks, because that easily could have been avoided. And the
Yeah.
thing is, he
It was
probably
sad.
knows that too. He
And it
probably
was
knows that it could have been avoided.
sad because he was probably maybe in his 40s and was otherwise an able-bodied adult and fully cognitive and just got kind of left there. So
Yeah, that's so sad. That is very sad. There's no reason for that to happen, and we're in America. I mean, and it happens here. Think about, I mean, that's crazy. So let's keep going. Mobility training with assistive device. So like I said, we're going to get up and start walking on one leg post-op day 1. I mean, way before we start walking with a training prosthesis, we're going to start working with a walker and then crutches, because you got to prove to me, if you think that you're going to spend all this time learning how to walk on a fake leg, and you're going to spend all this money getting it, you better be able to walk around with a walker or crutches too. That sometimes has to be explained to people that are like 80 or 90 that have an amputation, and then you try to get them up on a walker and they can't stand up on a walker even a month after their surgery, but they still want to get a prosthetic limb. And you have to kind of tell them, look, you can't even stand up with one leg in a walker. So we got a lot to do before we can even think about getting a leg. Sometimes you have to have that little reality check with them. But mobility training with whatever device they can walk around with. Residual limb care and protection. So doing a lot, bandaging it, keeping it bandaged. We'll talk about compression in just a minute. We talked about care of the remaining limb, making sure that you don't, if they're vascular, that they don't, that they check their shoes every day, they check their feet every day. And even if they're not, even if this is not vascular, if there was trauma, even if it was trauma, we need to remember they need to take care of that remaining limb, because it's really the only one they've got left. That's the only good limb they have left. So they need to take care of it. So making sure they're not getting skin breakdown, and they're not getting overuse injuries on their remaining limb. They need to do skin checks on their residual limb every single day. Even when the nurses are looking at it and stuff, they need to start doing it then, to get in the habit and to learn it. Especially when they start wearing a prosthesis, that's when they really have to do skin checks every day, because to make sure they're not getting breakdown. We talked about positioning. You always want to just try to, with no matter what kind of contracture, just try to always prevent hip and knee flexion contractures. That's what you want to try to always prevent. And for both of those, the best position for either a transfemoral or a transtibial is always prone, because if you're laying in prone, think about it, your femur is getting stretched out, you're stretching your hip flexors, and if you're transtibial, then your remaining tibia is falling down due to gravity, and so that'll be a stretch. So prone lying, even you can just tell somebody, as part of their home exercise program, just make sure you lie prone on the bed, or prone on the floor, prone on a couch or yoga mat for like 20 minutes every day. Prone on elbows, or just prone flat. And that's all the stretching you got to do for your hips and knees. And avoid prolonged sitting for those with amputations, because again, that keeps the knee and the hip in flexion. And so that keeps those remaining structures on the residual limb in flexion. And we always want to promote as much hip and knee extension as we can. So if they're lying in the bed, nurses love to prop people's residual limbs up on pillows and blankets and towels to make them comfortable. If you see that, I don't care how long I don't care how long it took the nurse, you take it all away and you make their leg go down flat, and you tell the patient, you keep this leg down flat. And then if you see a tech doing it, or you see a nurse doing it again, ask them nicely. Don't tell them not to do it. Ask them nicely if they would mind keeping it flat, so you can, because you're trying to prevent contractures. They will listen to you if you ask nicely. If you tell them not to do it, they will do it anyway and laugh in your face. But way before they have a residual limb, they've got to be able to transfer themselves, just like any other patient transferring out of a wheelchair. Now, if you've got two arms and a leg and a remaining leg to transfer with, it's going to be pretty easy. You can do it with an arm and a leg pretty easy, or some of these people will, a lot of them will use the sliding board. But transferring with two arms and one leg is basically just a squat pivot over. They just do a squat pivot over. They usually don't even have to take the armrest off. They can go either direction very easy. Usually it takes 5 minutes to train them on that. Now, if they're deconditioned, it is because they've been in the hospital a long time. They might have to spend a long time doing it, but usually if they've been sitting up a lot on their own in bed and doing therapy and acute care, transfers will come pretty quickly to them. Now, if they're a bilateral amputee, you're going to do sliding board transfers with those people. Now, you'll do a lot of sitting balance activities with them too, because they don't have a lower extremity to prevent them from falling forward. So you got to really work on their all their core muscles and especially their back extensors for balance, so they can use their arms and they won't fall over during a sliding board transfer. But you should, with amputees, I would say my rule of thumb, even if they still have a remaining limb, I would always start off with a sliding board. And then if they have a remaining limb and then they think it's too easy and they just think it's easy enough to do it without it, that is awesome. That makes them that much more independent. But always give a bilateral amputee a sliding board. And then honestly, to tell you the truth, a lot of times bilateral amputees are going to end up doing their transfers without their level surface transfers without a sliding board anyway. They'll just use it to go up or downhill most of the time. Let's say blah, 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 blah. Strengthening. Here's what you'll want to listen to for lab on Tuesday. So please look at the lab handouts that I have for lab next week, because this is what the first skill comp is going to be on. One of the skill comps, you have 2 in one day, orthotics and amputees and prosthetics. But this is where the strengthening differences come in versus transtibial versus transfemoral. Okay, so think about but also these, don't try to just memorize this and just try to get lost in it. Also think about what muscles or structures are missing and what structures are taken away when you're thinking about these two. So when a person is a transtibial amputee, the most important residual limb muscles we want to focus on are the knee flexors and extensors. So we really want to focus on their remaining quads, their quads and their hamstrings, okay? So they're going to have a tibia of any length is all we care about. Even if it's just an inch of tibia, that's okay. We need to focus on quad and hamstring strength, okay? Now, if they're a transfemoral amputee, think about this. They don't have a rectus femoris anymore. Or if they did, they don't have all of it anymore. And they might not have all their hamstrings anymore. They don't have a knee. So they don't think about it like this. They don't have quads and hamstrings anymore. There's no knee. So with transfemorals, we need to focus on hip extensors and abductors, abductors, okay? So let me go over those again. For transtibial, we need to focus on quads and hamstrings are the most important. In transfemoral, hip extensors, glutes, and hip abductors, glute medius, TFL, maybe some of the external rotators. Those are going to be the most important. Now, That doesn't mean don't work out other things too. Still on both of them, still work out. Like with transtibials, I still need you to work out the hip extensors and the abductors too. And for both of them, you still need to work on the adductors too, because you need the remaining adductor strong too. But these are just each of these two amputee levels, just think of them to make it easy. Transtibial, quads and hamstrings, transfemoral, glutes, abductors, or glute max, glute med. And then you also need to have really strong scapular depressors and elbow extensors. So you need to have really strong lats, really strong traps, like lower and mid traps, really strong rhomboids, and really strong triceps. That's important, and you might be wondering why. Well, when you're walking, first of all, when you're learning assistive device walking with just with a walker and crutches and no prosthetic limb, with just your sound limb, that's the only thing holding your body weight up between steps, are your scapular depressors and your triceps. So you've got to make those strong. Also, when you're when you're transferring, especially if you're a bilateral amputee, you've got to have strong scapular depressors and triceps to get you over, because if you don't, you'll never get over on that sliding board because you don't have a leg to push you up with. You've only got those arms. So you've got to have strong lats, strong scapular stabilizers, and strong triceps. Okay, so all of these things are very important. So just think of it as far as picture, and don't try to just memorize it just for the sake of memorizing the words. Try to picture a person with that body setup, with that part of their limb missing, doing a transfer, and what they would need to focus on. Okay, mobility. Okay, gait training. So stability, it's a question of stability versus flexibility. So when this is where I was talking about maybe somebody, we always want to make sure before we get somebody's hopes up that they're going to get a prosthetic, because not all amputees are going to be what we call a good prosthetic candidate. They have to show, like I said, really the best way to show it is, can you walk? First of all, can you stand with a walker with just your one leg and a walker? Can you walk with a walker and one leg? Now they try crutches. If you can walk with crutches and one leg, then that means you're probably a good prosthetic candidate. And then we're going to go ahead and pursue a prosthesis for you. If you can't get beyond a walker, then you're probably not going to be a prosthetic candidate at that time. Now, it could be a problem of strength and endurance, because maybe you were in maybe you were in a very traumatic accident and you were in ICU for a long time. So you've lost a lot of muscle strength, you've atrophied a lot, and your cardiovascular endurance is poor. Maybe you're not a candidate then, but you have the ability to go to rehab, work out, and get stronger, and then come back and then be a candidate for a prosthetic. That can happen later. They'll just put it off until you're strong enough for it. Or, some people, I've had to have that conversation with a lady one time. She was a very old lady, and but very, very sweet, very, very nice, and very, very sharp, very, very funny, and made fun of me all the time because of my Southern accent. She had a transfemoral on one side, and some home health therapist had went ahead and got together with a prosthetist and ordered her this prosthetic leg that was for a transfemoral, and it was she couldn't put it on. She didn't know how to put it on by herself. She didn't know how to use it. They just gave it to her and discharged her from home health. So she came to see us to learn how to use it. Well, she couldn't even transfer herself. So that was my number one cue right there. If you need, she was we got her to min assist with her squat pivot transfers, but for a long time she was sliding board, and she was like mod assist with a sliding board using 2 arms and a leg. I mean, and that's not very strong. That's not really good candidacy for our prosthesis. And so after we worked for a while, I made it her goal was we really focused on her transfers, because that's what I knew she needed to be most independent with. And she accepted the fact that just putting the prosthesis on took too much of her strength, and to even put it on correctly, and she just didn't think it was worth it anymore. So, and that doesn't mean she was giving up. That just means that she accepted the fact that she was just too weak to put it on by herself, and it was too heavy for her to use, and that somebody just gave it to her without seeing she was able to use it, and that she was probably just too old and weak to use it. But she did accept the fact that she was getting better with her transfers, and that she was getting to where she was more independent with her transfer and wheelchair mobility. And that actually meant a lot to her, that she could move herself around in a wheelchair. So in the end, she felt like we met her mobility goals, even though she never got a leg. But she was able to get herself around in the wheelchair, move herself around her house by herself. So in a way, we did make her independent, just in a different way than what we thought we were going to do. I've mentioned skin inspection every single day, even if they've only walked for an hour versus being on their feet for 12 hours with that prosthesis on. They need to check their skin every time before they put it on and when they take it off, because there's always a chance that you can get a wound. Okay. There's always a chance that one day you don't put it on quite right, and maybe you've worn the same prosthesis and components every day for 10 years, and one day you put it on and you do something just slightly off, not even thinking of it, you can't even feel it. It could be enough to give you breakdown that day. So you wouldn't know it if you didn't check at the end of the day. So you've got to always tell your patients to look at their skin.
So is this applicable with things like if you have a TKA and you've got one of those giant braces on your leg and it's like rubbing on your medial malleolus?
Yep.
Yeah, kind of the same thing?
Yeah, but not yes. Well, yes, but those types of orthopedic braces that are on there after joint surgeries, those really need to stay on, and they might rub a little bit, but I'm talking about, these are going to be more like real pressure injuries than just like something that just looks red.
Okay, thank you.
Yeah. We talked already about phantom limb sensations and phantom pain. That's going to occur in about 80% of amputees. A lot of times, putting the prosthesis on and putting pressure through the residual limb helps get rid of the pain. So just like last semester with neuro, I was all about screaming weight bearing in your face every day, telling you weight bearing, weight bearing, weight bearing cures everything. Even with phantom pain, just put your prosthesis on and bear some weight through your leg, and the more you use your leg, it can help get rid of the pain. Sometimes modalities like ice or TENS will work. Not a lot of times do they, but sometimes they do. A lot of times just like ice massage or massage with like a towel or with like just your hand, like a deep massage will help. Sometimes maybe steroid injections can help. Not everybody has to get anything medically done, and some people will get it to where it's not even enough to where they even get medical intervention. It's just something they live with. But most of them, they'll have it to some degree of it, some degree of pain. Energy cost. This also has to do with prosthetic potential. So think about this. If you have this, when you have an amputation and then you get a prosthesis, your energy expenditure of walking automatically goes up. So if you have one transtibial prosthesis, the energy expenditure is up to 20% more just to walk the same distance than as a person with two regular legs. If you have a transfemoral, it's up to 70%. That's a lot. Those people with transfemorals walk slower, usually, and they usually take a lot more rest breaks. And sometimes they use a wheelchair for some of their daily activities, and then for like longer distances, and then walk the short distances. And then if you have a bilateral transfemoral amputation, your energy expenditure to walk the same distance is 300% more. So just to give you a picture, let me see if I have this video. Oh, I don't have the video. When you have a transfemoral amputation, you basically have nothing really, but you're basically the only way you're standing on locked knees and a locked ankle, and you have to stand leaning forward against bilateral forearm crutches or a walker. Okay, you have to keep your weight forward like that, because that's how you keep yourself upright. Because if you stand all the way upright, you're going to fall backwards, and there's no way you can step backwards and catch yourself. They have to basically shift their weight over onto one prosthetic leg and use their trunk and remaining residual limb to kind of perform a circumduction of their prosthetic limb to get it forward. And then they shift over and circumduct the other prosthetic limb to get it forward. And that's kind of how, and they do that with forearm crutches or with a walker. That is very energy taxing. Those people, I'm talking like they go about 10 feet with maybe two people holding on to them, and then they've got to sit and rest, and they're huffing and puffing and they're pouring sweat because it took so much energy just to walk that 10 or 20 feet. Now, that doesn't mean, now let me say this, after I said that, that's not every single bilateral transfemoral, but almost every single bilateral transfemoral is never gonna walk functionally in the community. They're probably gonna do it just for exercise at therapy or set up at their house. You know, they'll have their prostheses and their walker, their crutches at home, and they'll have somebody there and they'll walk for exercise. And that's totally what they need to do. If somebody's a bilateral transfemoral, we need to do gait training with them to teach them to walk for exercise, because it is really good for them. But just think about it. It's not going to be functional to get around at your house. If it takes you that much energy and you're that slow, you're not going to be able to go to work and get anything done if it takes you that long to get around. So these people just walk for exercise with their prostheses, and that's okay. That's totally fine. And some of them, after going through prosthetic training and seeing how hard it is, some of them will come to a point where they're like, you know what, it's just too exhausting, and it takes me too long to put about 2 prostheses on, and it takes me and my caregiver too long to do the exercises. I'm just going to work on my strengthening and mat exercises and stretches, and just worry about getting around in a wheelchair, because it's much more functional and I can hold down a job or go to school that way. And you know, that's probably the best decision. And honestly, when you're thinking about life independence and being a part of society, that's probably the best decision anyway. So when a person chooses to not get a prosthesis, it's not a bad decision and it's not a failure. It just means that they weren't just a candidate, or there were other reasons that they couldn't get it. But most people do want to get one, and most people are appropriate. Okay, so how long is it going to take to get somebody from getting a limb cut off to walking?
So
Okay.
I have a question in regards to the last slide. I'm sorry to interrupt.
Okay.
So you were saying that sometimes it's just more functional to put people in a wheelchair instead of use their prosthetic devices or whatever. And you were saying that sometimes they just want to strengthen and work on things like that. But couldn't it eventually kind of turn into, okay, I'm strong enough now to use my
Oh yeah, definitely.
like, kind of like
Because
walk before we run kind of thing?
exactly, I'm glad you said that. It can be like that because and I've seen that happen. And I didn't treat this guy when I worked at Tier Outpatient. There was a guy that I don't know how his amputations happened, but he was a bilateral transfemoral, and he was a high transfemoral on both sides. Like, he didn't have a lot of femur left on both sides, and but he walked with. They did his gait training with forearm crutches, and he was also overweight. Now that man, his walking wasn't pretty, and he never took his prosthetics home. He's kept them there at therapy, because they were just so big, and he didn't use them at home. He only used them in therapy. But it he worked so hard to walk 10 feet. It would probably take him 15 minutes and like 2 rest breaks, and like 2 people with gait belts holding on to him because of his size. But he would do it. But he wanted to do it because he knew it was good cardio for him, because he was trying to lose the extra weight. That was a big problem for him, because he wanted to be in a manual wheelchair so he could push it to keep his arms strong, but he was overweight, so he wanted to work on gait training, so that would also work on losing weight too. So, and I'm telling you, this man lost a lot of weight quick, because walking 10 feet with bilateral transfemorals, I've never seen a person sweat so much working out. And I mean, that man was incredible how hard he was working. And I mean, he was just I've never seen somebody work so hard. I mean, he just made me feel ashamed of just complaining of things sometimes. But yeah, it takes a lot of energy. But sometimes, like that guy, like, he just chose, I'm not going to use prosthesis in everyday life because it's just too much trouble and for right now, but maybe one day. But I'm going to still use them for exercise. Whoops.
Thank you.
You're welcome. Okay. So prosthetic training. Usually when they're seeing us, we're seeing them in rehab, and inpatient rehab, or even outpatient. They'll go see the prosthetist by themselves, or they'll see them with us, either one. Some of them like to do co-treats with us. Some of them just like to consult with us over the phone. Either one's fine. They'll get their prosthetic made they'll start off either with a mold of their residual limb, or they'll do a computer scan of the residual limb and kind of do it out with the computer program. Either one's, they're both in use still. Either one can be good. We do all the education. We're about to talk about all these. We do education on skin checks, like I talked about, wearing and walking schedule. Just like for orthotics yesterday, when you first get your prosthetic, you're never going to just put it on and wear it all day. You're just going to wear it for 30 minutes to an hour, just like your orthotics. And then you're going to take it off and do a skin check immediately. Note any areas that are red. Let your therapist and the prosthetist know if there's any areas that are red after 20 minutes. Every day, try to build up an hour until you get to 8 hours. And if you can make 8 hours without any pressure areas, then you can wear it all day long. And that can be a combination of sitting, standing, walking, all of that when you're wearing it. That's training we have to do. Now, these other things, socks, liners, we'll talk about all that next. I was talking earlier about how there's layers of a prosthetic limb. There's not just that hard plastic socket they stick their leg in. There's actual layers of a prosthesis. So we're going to talk about the components next, okay? And let me end the slideshow a second. Let me just see one thing. I want to see how many slides we have left. Oh, we're good. We only have a little bit left and we have a lot of pictures coming up, so we're good. And then that's all we have for today anyway, so y'all will be out of here soon. Okay, components of a prosthesis. Let's start at the bottom at number 5. I always like to start at the floor and work my way up, okay? I think it's easy to think that way. So first you have the foot. It could be made out of, the most common foot is made out of wood. Some people will still get a wooden foot. That's what Medicare pays for, and that's used. Sometimes they call it the Medicare foot because it's just a common foot that Medicare or Medicaid people get when they can't buy anything else, or to be made of metal. Most feet are made of metal. Feet can be a single axis at the ankle, so it can provide a little bit of dorsiflexion and plantar flexion, or it can be multi-axis, so it can allow eversion and inversion too, so that you can walk on multiple different kind of surfaces and your foot always acts just like a normal ankle. Okay, so that's the foot. Then you have what we call the pylon. Okay, the pylon, all that is just the metal rod that you see that attaches the foot to the lower leg. That's all that is. It's just that piece of metal rod. It's called the pylon. Okay, then you have the socket. The socket is probably, besides the foot, the socket is the biggest part of the prosthesis. The socket is the molded plastic part of the prosthesis that contains that whole residual limb, okay? It's what the residual limb fits into, okay? And it's probably going to be the biggest part of the prosthesis. It'll be the most noticeable part of the prosthesis. And it's made out of a hard shell of plastic or carbon fiber, and it's been especially molded to that person's bony prominences, their limb girth, and everything. Then there's a layer of socks that they wear, and I'll explain the socks in a minute. The socks are worn every day because there's always going to be fluctuations in residual limb edema, and we're going to go over that in a minute. And then finally, you have the liner. The liner is what goes against the skin. The liner is like made out of rubber or silicone. It's the only layer to touch the skin. Nothing else should ever be touching the skin except the liner, okay? It touches the skin directly. You roll it on, and I'll show you a picture of a liner in a minute. There's different kind of liners, but they're all basically the same, look almost the same. They're made out of rubber silicone, and that's what goes on that's the first layer. Now we're going to go in backwards order. Then, depending on your edema, how much edema you have in your lower limb that day, because it changes every day, you're going to put on different layers of socks. And the socks go by plies, just like toilet paper or paper towels go by plies of layers. Prosthetic socks go by plies too. They can go from 1 ply all the way up to 10 ply, with 10 being the thickest, okay? So if you woke up one morning and your edema was really, you had a lot of swelling, you would put your liner on, and then you would just wear maybe 1 or 2 plies of sock and put in your sock, and then put in the socket. But if you woke up one morning and you had no edema, you might need to wear 8 layers of socks over your liner so that you can fit in the socket. Okay. So those socks are basically just there to take up extra space inside the socket because of fluctuations in edema of the residual limb. Does the sock layer changing every day confuse anybody? Okay, good, because sometimes it does. Let me see. No. Now, let me talk a little bit more about that fluctuating edema. You all know edema is swelling. Well, think about this. You have an amputation. It's a clean cut right through a limb. Well, not only do they cut through the bone, they cut right through the muscles. Well, they cut through arteries, they cut through veins, and they cut through lymphatic vessels. Well, because of all that, they try to put arteries and veins and lymphatic vessels back to where they're in a circulatory pattern again. So that the artery will go back into the vein like they would at the bottom of the leg. But I mean, we can't get it perfect, especially the lymphatic vessels. Those are the most ones we can't really do much with. So the ends of prosthetic residual limbs tend to swell all the time, and they're always for the rest of your life, no matter from day one of your after post-op to the day you leave this earth, you always are going to have fluctuations in your residual limb of edema. Okay. Now, at night, you wear this thing called a shrinker. That is all it is like a compression sock that people wear on their ankles during exercise so their ankles don't swell. But shrinkers are made specifically for you, so they're made, a prosthetist will measure you, and it's made out of this really stretchy but really tight, like neoprene type fabric. And you pull it on and roll it up, and not the easiest thing to get on, but as after you do it a few weeks, the person gets pretty fast with it. They wear that at night. So at night, when they're not wearing their prosthesis, they're always wearing their shrinker. Okay. So when they're bathing, they're not wearing anything on the residual limb. But when they're not wearing their prosthesis, they always have to be wearing their liner. Okay. So the only time they can take anything off of their leg is when they're bathing. When they're sleeping, obviously they won't have their prosthetic leg on them, but they have to keep their liner on all night, because if they don't, they're going to wake up the next morning, and overnight their residual limb is going to be so big that they probably will not even be able to get their leg inside of the liner or the socket that day. And then they won't be able to leave home. And believe it or not, that does happen to some people. And when that happens, it's not the end of the world. They just have to prop their residual leg up really high on something high, like a stack of pillows or boxes higher than their heart, massage the fluid out until they can get their liner on, and then or put their shrinker on for their shrinker to help too, and then they can eventually get everything on. Might take them a couple of hours or a little while, but they can eventually get it on if they've woken up swollen. But that's why it's so important that they always wear that liner on anytime they're not wearing their prosthetic limb. And if they take off their prosthetic limb during part of the day just to give their limb a break or their skin a break, they need to take that liner off, take the socks off, and put that shrinker on, even if it's just the middle of the day, even if it's just for 30 minutes, because their edema can come on that quick. It's that big of a deal. So this is just about the care of the prosthesis. This is nothing really anything hard or anything. So the liner remember, it's silicone or rubber or a combination of the two. It can only be hand washed, or oh, I'm sorry, it can be machine or hand washed. It is safe to put it in a machine, but you can only air dry it, okay? Because it's made of rubber and silicone, and if you put it in the dryer, it's gonna melt into all kinds of weird shapes. So you can only air dry the liner, okay? The socks can be machine or hand washed, but you can only air dry them or they will shrink because they're just made out of cotton, okay? And then they won't fit right. The socket itself, that's the plastic part. Now on the inside, you might not think this, but the inside is going to get really nasty every day. You might think you're a clean person. I don't sweat a lot, but sweat is going to leak through that liner and those socks. And that socket can get really nasty at the end of the day, especially at the end of summer. I promise you, I'm not making this up. I've seen people in therapy and just like walk in the middle of the day in therapy, walking from the parking lot, and they would sit down on the mat, take their leg off, turn their leg upside down, and sweat would drip out of the socket because they were sweating so much. So the sockets get nasty every day. So every day, at the end of the day, they need to. Now, you never put the socket in the washer, of course, and you don't spray it down with the hose. You need to wash it with wash it with antibacterial wipes or alcohol wipe, large antibacterial alcohol wipes or biocidal wipes, or you can make a mixture of 50-50 or 70% alcohol and 20% or whatever percent water, or you can make a real light bleach water solution and you can spray the inside of that and wipe it out and just let it air dry. And that'll always be the only thing you need to do. But you got to do it every day because, believe it or not, if you don't do that every day, you will grow fungus in your socket. And that will eventually start to smell. And if you don't catch it by the smell, you will catch it with getting fungus on your residual limb. And that's no bueno. So
So when you're working with patients that do have prosthetics, two-part question. One, do you personally wear gloves? And two, how do you kind of put them on in a way to not offend the patient? So they're not like, oh, you think I'm gross? You know what I mean?
You mean like, no, I don't, you mean like you don't know if they've been washing the liner or the socks, so you wear gloves just in case?
Yes.
Oh, I see what you're saying. Um, I mean, you could wear gloves just like, and you could just say, "Oh, I wear gloves with every patient anyway." I mean, some people really do wear gloves with every patient. But I mean, if they look clean, I mean, I will tell you this: most people. I've never had a patient that did not keep all of their components clean. I mean, their socks were always bleached white, or if they were colorful and like design socks, you could tell they were clean. I never smelled anything, but yeah, I saw people pour sweat out of their socket because it was the middle of this day in the summer. Now I'm not gonna touch their socks. I'm gonna say, you deal with that, buddy. You know, you can wring those socks out or change them, but don't, I'm not gonna touch it. But just use common sense, and they won't be offended if they're sweaty and you don't want to touch them. Just say, hey, can you dry yourself off before I help you? They won't be offended.
Okay.
Because they get sweaty, and believe it or not, some people resort to using antiperspirant on their residual limb if they sweat enough, especially in the summertime. And a lot of people, believe it or not, a lot of the lower extremity amputees that I've met in Houston, they use spray deodorant, not deodorant. It can't be deodorant. It has to be just spray antiperspirant, and they'll spray it on the residual limb so they don't sweat as much. And it works really well. Something about the combination of the deodorant and the antiperspirant messes up their skin and gives them like these weird irritations with that met with the liner and the socks. So it has to just be antiperspirant, but the spray is what we recommend if they sweat a lot. But not everybody sweats that much. These are usually just like these are usually more people that are really active in the summertime. Shrinkers and socks. I talked about residual limbs fluctuating. Need to wear the shrinker at all times, except when the prosthesis is not on, or if you're bathing. If you lose your shrinker, or can't find a shrinker, or if you're a brand new patient and don't have a shrinker yet, you can wrap with tight ACE wraps, and we'll do some of that in class. That is in your packet that I've got for you on Blackboard. Obviously we don't have a fake prosthetic leg or wrap on Tuesday, but so we'll try to mimic it however we can. But it's just like doing a figure 8, starting at the bottom, and you always want to wrap tighter distally and then loosen up as you go proximally, so you're always squeezing that fluid up the residual limb if you do it with a shrinker. I mean with a ACE wrap. But once you get the shrinker, it does it for you, and you never have to think about that. Some days edema is, like I said, edema is going to be different every day. So some days they may wear different piles of different plies of socks than other days, and also they may change plies during different parts of the day. So they may start off with 3-ply in the morning and then move to 5-ply in the afternoon. Or by the time they get dinner time, they may go to 7-ply if they're a little bit less swollen, if they need to fit in their prosthesis more, or if they've been working out a lot, if they went for a long walk or a run and now they're swelling a lot and now their leg is real tight in there, they need to remove some ply. So they'll take away and maybe only wear 1-ply. So they always keep several plies of socks with them at all times. I've never known an amputee that didn't keep an extra set of ply of socks with them all the time. Whoops, I don't know what that was. Okay, this is an example of shrinkers. So a lot of pictures coming up, so not a lot of words. We'll get to the rest quick. So you can see, now this one guy over here it looks like a 2-layer shrinker on. These over here, these are on the right hand side of your screen. The long skinny one is more of the shape of a transtibial shrinker, and that's what the man in the picture is wearing. And then the shorter, fatter one is one that's more indicative of a transfemoral shrinker. And you can see how they're made, they're tiny at one end. And the goal is no matter what type of amputation, the goal is to always get your limb to a cone shape. You always want it to be a conical shape, because that'll be the most efficient way for it to fit into the prosthesis. These are socks. They're really no different than any other socks that we wear, except they're just shaped a little bit differently. Most of them come in a white, but they can come in any color you can think of. They can come in any design or pattern you can think of. So you'll see just any sock you can imagine. You'll see it on amputees too. So answer me this. I've already told you all these answers in a different way, but in different words. So I'm going to quiz you all real quick. So you have a patient and they come in, you're an outpatient therapist, and they come in to see you and they say, I've got some redness on my residual limb today. Oh, wait. Yeah, I've got some redness on my residual limb today, and it's really high on my residual limb. So what do I need to do about my socks? can anybody visualize what would be happening? If your redness is too high on your limb, what do you think is going on with your socks?
Would you add more socks?
You would actually, I'm glad if this stumps everybody, and it always stumps me. I have to rethink it every year. You would actually remove socks, because if your redness is, if you're getting redness too high on your residual limb, and it's a sore that's getting redness where redness usually doesn't occur, that means that your residual limb is sitting all the way in the and bottoming out inside the socket, okay? And one thing we never want, and I didn't tell y'all this, so this is why y'all need to get the answer right. You never want the end of a residual limb to hit the end of the socket. You always want it to float, okay? Because if we put weight through the end of a cut bone, that would make the biggest wound ever, and it would never heal, and we could never walk on that. So we always float the end of the residual limb and bear the weight on another place. And that's coming up in just in a minute. But back to the redness. So if the redness is too high, that means my limb is too far down in my socket and I'm bottoming out. So that means I need to put on some more socks. So maybe, Willie, is that what you said? Put on more or take them off?
I said add.
Yeah, okay, then you were right. So I have to explain it in order to say it, in order to get it right. So then you would add socks so that the bottom of their residual limb would not be bottoming out, and then they wouldn't be getting that pressure high on their limb. Okay, so picture that. Now you're all confused. I'm gonna go with the opposite. If they came in to see you and they say, you know, I usually, where the redness usually is and goes away, today it's down too low. It's lower on my leg, and it's not going away. Then you would need to say, that means you have too many socks on your residual limb. You need to take them away because they're getting pressure on the end of their residual limb, and it actually needs to go down further in the socket. So they would need to remove socks. So I know I just confused all of you with that. That confuses me every year, and I have to explain it 2 or 3 times to myself sometimes. So just go through it in your head. We'll talk about it in lab. I'll go through the I call it psychology. We'll go through psychology again, and I'll make sure it doesn't confuse you. Okay, so don't worry about that. Let's see what this is. Okay, so therapeutic options. So what we do with prosthetic training. One thing before we get into that, one thing I want y'all to know that I left out of one of these slides, and y'all need to know this, and this is very, very, if you don't hear anything else today, you got to know this. I just said that we never want to bear weight through the end of our residual limb, because if we did, that would make a big wound, correct? Well, so where do we bear the weight if it's not on the end of our limb? Well, if you're a transtibial amputee, they make your socket to where you bear all of your body's weight on your tibial tuberosity and your patellar tendon. They do that because those areas are very pressure tolerant. So actually, when you're walking on your prosthetic side and it's a transtibial side, you're actually standing and putting all your weight through mostly where your patellar tendon is. And it's that soft part right there where they hit with the reflex hammer. That's where almost all the weight is, and a little bit on the tibial tuberosity, just at the top of it. That's all transtibials. That's where they bear their weight. Now, if you're a transfemoral amputee, it's a little bit different. They don't really have, their whole leg doesn't have a bony prominence to to put weight through. So a prosthesis for a transtibial amputee is actually going to come up to their pelvis, and it's actually they're actually going to sit on their ischium. So their ischial tuberosity is actually going to come in contact with the prosthetic limb. So it will almost be like they're standing on one leg, and then they've got their prosthetic femur, or they've got the residual femur put down in the socket, but all the weight of that side of their body is sitting through their ischium. So they're almost sitting down on that side. It's kind of weird to visualize and think about that. So when they get redness, if a transfemoral is going to get redness, they're probably most likely going to get redness at the ischial tuberosity. And they have to, when they do, and they almost always do the first few times they train with a prosthesis, they have to get it modified and padded enough so where there won't get breakdown over that. And the same thing goes for the patellar tendon and the tibial tuberosity. They usually have to modify it up the first few weeks so that they don't get too much pressure on there. But for both types of amputees, those are where you bear your weight. So I'll say it again: transtibials, patellar tendon, and tibial tuberosity, and transfemorals, they bear their weight on their ischial tuberosity. And then just a side note, a transfemoral prosthetic is sometimes called an ischial containment prosthesis because it contains the ischium. Okay, real quick, what do we do with people with a prosthesis when they finally get it? Okay, so now they've got the prosthesis, what do? Well, we always start in the parallel bars, whether it's one prosthesis or two, because guess what? They're standing up with their new leg for the first time. It feels strange to them. It feels strange to their brain. They're scared. It's a brand new thing. So we always start in the parallel bars, okay? Always give them, that's the most place where they can get the most stability. So you're going to work on posture. They're going to want to always look down. I'm telling you this from experience. They think if they stand all the way up straight, they're going to fall backwards because they only can feel one leg. They got to learn to trust that other leg that they can't feel, that they don't know was there. You have to work on head turns, turning side to side, up and down. Then let go of the bars and do that. That's scary for them. Then hold on to the bars, just like we did in neuro for pre-gait. Work on weight shifts forward and back, right and left and diagonal. Work on shifting your center of gravity different places over your base of support. Then we would do, we could do step ups. We could do stepping forward with one extremity and stepping and I would say we would always step up or forward with our sound leg and leave the amputated prosthetic leg back behind, because what's that kind of doing? If we, like in neuro, we called it forced use. So does that make sense that we would want, it's almost kind of like forced use for amputees if we always keep the bad leg in the back? Make sense? Okay, so let's talk about it again then. So if you're standing in the parallel bars and you have them doing step ups like pre-gait, well, let's say they have the prosthetic limb on the right side, you would want them to do their step ups at first with the left leg. Why is that? Somebody say it.
Can you repeat it again?
Yes. Okay. So everybody visualize this, because I want to make sure y'all see this. This is once you visualize it and get it, it's just like last semester's neuro force use. This is just amputees now. It's just a little bit different, but it's the same concept. Okay, so let's say that we have a patient and they're standing, they have a prosthetic on their right leg. Doesn't matter if it's transtubular or transfemoral. It's on their right side. They're holding on to the bars with both hands, and we have a box in front of their left foot. And you, as the PTA, say, I want you to shift over and step up onto the box with your left foot. Okay. Now, they're going to be scared to death to do that. But can you think of a reason why am I making them shift and step up with their good leg first?
For the weight bearing?
For the weight bearing. So just like weight bearing is all where it's at for neuro patients, when you're working with amputee patients, you always need to be doing all of your strengthening and all of your training in weight bearing with that prosthetic on, because that's how they learn to use that leg. Now, yes, you have to eventually teach them swing phase too, and how to control a leg in swing phase, but they've got to learn how to trust and put their weight on that leg first, or they will never take a step. So you start off in the parallel bars, just doing step ups with the sound limb. And if you are you are usually sitting on a stool in front of them in the bars, holding on to their gait belt or blocking their prosthetic knee so that it doesn't buckle while they do that, or you're holding on to them to give them courage, because they're scared of this, because you're making them stand on a leg that they can't feel, that they can't see unless they look down at the floor at it. So this is really scary for them. Then you start working on step ups with just holding on one hand on the bars. And then you switch over to just the other hand on the bars. And then you put a ball under their foot, like a basketball or something. And you ask them, can you roll this? And I'm talking about let's say again, they're in the parallel bars, and they are standing, and their prosthetic side is the right side. So we put a basketball under their left foot. We say, stand with this basketball under your foot, and just roll your foot on the ball forward and backward, roll it in circles, roll it in diagonals, just roll it around, all while you're holding on to the bars and standing on the prosthetic limb. That is making them do a lot of force use and co-contraction of their residual limb, and that's the kind of strengthening they need. That is the weight-bearing, closed chain strengthening they need as an amputee. So you could put a ball under their foot that's something unstable. Maybe if that's too scary and they're not ready for that, maybe you can put a rubber disc or foam under one foot. So they're standing with their uninvolved foot on an unstable surface and their prosthetic limb on the stable surface. And then they can shift their weight side to side like that if they get brave. And then you can even start taking steps forward and backward. So it's almost in a way is like pre-gait training with a neuro patient and force use training with a neuro patient in a way. Taps the prosthetic foot. So where this says unaffected ball on the unaffected foot on ball, if you put it, and this says go slow and fast, different sizes. You know, if you put your unaffected limb on a small little ball and roll it around, it's going to be easy for them to stand there. So if I put my foot on a tennis ball and my left foot on a tennis ball, and you told me to roll my foot around while I held on to the balls, it would be to the bars. It would be easy. But if you gave me like the basketball, it would be a little bit harder for me to do that. It would take a little bit more balance. Also, the faster I go, it's going to be more challenging to my balance as well. Another way that, and this is, and you're going to think I'm sounding completely crazy here, where this says tap the toes of the prosthetic foot for feeling vibrations. Okay, obviously there are no toes on a prosthetic foot. And even if there were, they could not tap them themselves. What this means is you as the therapist are using something heavy to tap their prosthetic foot for them to feel the vibrations coming up through the limb, the pylon, into the end of their residual limb, because we need to let them feel where their residual limb lies in that socket so they can almost get a sense of their proprioception and space back. Okay, so if you don't do that, they just feel like they're standing on one leg and they're floating in space. But what we used to do at Tier, prosthetic feet are hard and made of metal or wood, and you're not gonna mess them up. So we would take a big heavy hammer and we would tap on the toes and have the person, they would stand there with their eyes closed, and then we would tap on their toes of the foot a few times, of their prosthetic limb, not their sound limb, because we don't want to break their toes, on their prosthetic foot. And we would say, okay, did you feel, where on your residual limb did you feel that? And they would say, oh, I felt it on the front of my limb, or I felt it in the back of my limb. And then we would we would hammer on the back of their prosthetic heel of their foot, and we would say, where part of your limb did you feel that at? Now, they're never going to get perfect position sense of a residual limb, because there's just been too many structures and nerves that have been cut and put back together. But giving them a sense of feeling of vibration, we can give them a better sense of feeling where they are in the socket, and they're going to take off walking a lot faster if you do that early on. If you remember rhythmic stabilization from PNF, doing that at the hips and shoulders for balance in the parallel bars, obviously not holding on with the hands, but keeping their hands, but standing in the bar so they can grab the bars for safety, but doing it at the hips and the shoulders for balance, throwing their balance off their center of gravity, throwing and kicking balls like a light therapy ball or a light rubber ball, doing wall slides, like doing squats along the wall is a very good place to do squats. Or if you have a total gym, if you know what a total gym machine is, that's probably the best place for amputees to start off with doing squats, is on a total gym. Wall slides are a little bit more dangerous for transfemorals, especially transfemorals, but I would put them on a total gym first, but they can eventually do wall slides, and that's just wall squats if you've ever heard them call that. Forward walking, obviously, but you got to teach backward stepping too, because life is always not just walking in a perfectly straight line. Where we walk forward, we walk in zigzags, and sometimes we step backwards in the kitchen and things when we're doing things. So we have to teach backward steps too. But I'm not talking about walking backwards like down the hallway or like a certain amount of feet. I'm talking about just taking a safe step backwards in case you need to do that to catch your balance or prevent falling or to get out of somebody's way. Okay, so walking forward, when we'll do that during lab next week. Very, very, very similar to neurogate training. A little bit different, but very similar. Backward walking, you always want to teach a person with a prosthesis to take a backward step first. Which way is it? It's with their, can you hear me? I just got an error. Can you else hear me?
Yeah.
Okay, I got an error
Yes.
or something. Okay. What was I talking about? Oh, when you have a prosthetic, you always want to take the step backwards with the good leg first. Well, I'm sorry, with the prosthetic leg first, because then if you took the step backwards with your good leg first, your prosthetic leg would buckle. That's just the way they're made. Okay. Then you need to work on side to side walking too, because we move around in the kitchen, side to side. If you have to get to your side of the bed, if it's close to the wall, might have to take some side steps or get between furniture. It's just everyday life. Whatever we have to do in walking, we have to teach them to do the same thing, just with a prosthetic. Almost done, guys, I promise. Just more ideas. Diagonal walking, which is like the braiding, the karaoke walking. which we did last semester for neuro. Stop and go, or playing stop and go or red light, green light, where they have to start walking quickly and then stop walking as soon as you say stop. That is a very good game to play with amputees, because that is very hard for them to do because of their lack of control of that side and their lack of joint awareness, of their lack of proprioception and kinesthesia. So that is very good for them to do. Now, don't just do that on the first day they're walking out of the bars, because if you do, they're going to fall on the first time you try something. You know, give them an assistive device outside of the bar so they can get it, and then make sure and then if you're doing it with a walker, make sure they're safe. Then try it with crutches, then try it with the cane, and then eventually, when they're good enough, you can try it with nothing. But they can usually start pretty good. It's usually the stopping where they might kind of sway a little bit, or maybe take a couple of extra steps to stop. Just like neuro patients, first you start off working on set level surfaces, then you go to less compliant surfaces like foam, rubber, ramps, grass, curbs. If you got a parking garage, walk up and down the ramps of the parking garage, things like that. Tilt tables or rocker boards that you can stand on, and the parallel bars and that rock side to side that challenge their balance. Resisted walking, so putting like a TheraBand around them and then pulling them back, and they have to pull you forward when they're walking, or the opposite, you putting the TheraBand around and you pulling them, and they have to slow you down. Getting their arm swing back again, trunk rotation with arm swing. They lose that whenever they have an amputation, because at first they're holding on to the parallel bars and assistive devices when they're walking, so they can't swing their arms. And then when they start not holding on to anything, well, they don't want to rotate their trunk and swing their arms because it'll throw their balance off. So we have to reteach them that. That comes in with resistive walking too. Carrying objects. You can give them little weights to carry, give them things to carry across the gym and stack up on a shelf, because that's going to challenge their balance. When their balance is really good, I would give people a styrofoam cup of water, and I would fill it up about this much from the top. And I would say, okay, I want you to carry this. I don't care what hand you carry it in, but you've got to carry it all the way a lap around, however we were in, without spilling any of it. And even the best amputee is going to spill water everywhere. It's just kind of funny to make fun of them, and they're all like, "Oh, I can't do it," and they want to, and they really get into those games too when you challenge them on those things. But giving them things to do like that is actually a good therapy tool. Hold a cup of water and try to walk around without spilling it. For an amputee, if they can do that without spilling water, their balance is really, really good, because most of them are like walking kind of like per clunk, per clunk, per clunk. So if they can, we want to get them out of that. Oh, and one big thing here in the middle, teach them on turning, no pivoting in place. So if they're walking through a crowd or walking somewhere and they've got to make a turn real quick, we need to teach them to make a wide turn with their feet, and don't do a pivot on the ground, because that pivot will cause a lot of friction between the residual limb and the socket. And one time is not going to make a pressure wound, but if they get in the habit of doing it, it's always going to just make a lot of problems on the residual limb skin. So no pivoting. They need to turn like a robot or make a wide turn. Picking off objects off the floor is a great balance activity. A lot of weight shifting. They have to bend their prosthetic knee to get down to the floor. It takes a lot of core and glute strength. Getting up and down curbs and ramps and stairs. Walking at a normal speed. Eventually, we won't always work on running with them, but if they want to work on running, and that's one of their goals, and excuse me, for the dog, if they have the proper type of foot for running, and then we can teach them running. Now, I've never taught an amputee how to run, but other people that I know have, and they do very, very well. Those are the people that run on the what they call the blades. I'll show you some pictures of those in a minute. I'm not going to play, just for time's sake, I'm not going to play these videos for you right now on YouTube, but please watch these videos. This is just different stages of the rehab process with amputee strengthening, and it's just good to get, one of them's kind of long, but please watch it before live on Tuesday. It'll kind of make things come together and make sense a little bit more. These are different examples of prosthetic knees. This one knee that's singled out over here on the side, on the left side of the screen, it's called a safety knee. This is really the cheapest and the most basic knee there is out there on the market. Basically, if you have Medicare and you have nothing else, or if you have bad insurance and not a lot of money, this is what the kind of knee they give you. It's a freely swinging knee. It's kind of easy to control. It swings into flexion freely, and then it locks. When you swing it out, you have to kind of fling it out into extension during mid stance, and then the knee will lock for you at initial contact and through mid stance. And then you can see there's some little levers on it. Whenever you go, your body weight transfers over that knee in mid stance, the knee will unlock. And then that's when you're expected to hit initial contact on the other side. So it's unlocking as you're accepting weight on the other side. That's called a safety knee. That's the most simplest type of knee out on the market. These other knees over here, these 4 pictures are microprocessor knees. These are all these knees work with well, I think all of these are actually one of these are all microprocessor knees. There are some knees that are hydraulic knees that work with oil, different chambers of oil and air, but most of the newer ones out that most people have now have a microprocessor computer chips built into them, and they help your stability of your knee during swing and stance, so that you don't buckle or fall. And they also are very smart, so they're also able to keep up with your gait speed, and you can change gait speed, you can change running speed without having to reprogram your knee. On the first microprocessor knees, you basically could walk only at one speed, and then if you wanted to run, you had to basically take the remote out and switch it to run mode so that it would work right. But now they all are smart enough to where it adapts to your speed all by itself. There are just as many brands of shoes that are on the market. There's just as many mechanical and microprocessor knees on the market. John, the prosthetist I was talking about earlier today, I think he said there's he easily knows there's at least over 1,000 microprocessor knees out on the market right now. He obviously doesn't use all of them. He uses the ones that he thinks are the best. And he does work with some that are cooler than others at some times, depending on how high level the client is. And if they want to get into athletics and things like that, he'll have to use the high level knees, things like that. These are different prosthetic feet. So this one right here on the right side of your screen is a wooden foot. It's called a satch foot. Stands for single axis foot. It's usually made out of wood and rubber. It's the simplest kind of foot, often called the Medicare foot. But just because you use this foot doesn't mean you can't afford it. There was a few years ago, and I hate reality TV usually, but the show Dancing with the Stars, there was one season, she was a contestant on there, and she was an amputee, and she danced she went, I don't think she didn't win the season, but she went really, really, really far. And most all of her dances she did on a wooden foot because it was so stable, and because of all the choreography and all getting thrown up in the air by her partner they were doing, she needed something stable to land on. So she chose to dance with that wooden foot. And she did, and she wore it with high heels, and you would have never known the difference just by looking at it. And I never knew that until the prosthetist told me about it too. These other feet over here are multi-axis feet. They usually, sometimes they'll put a cover over the foot that you can see the plastic covers over that. That's just if they want it for cosmetic reasons. If they may, but usually that's going to go inside, that's going to be inside the shoe anyway. So people may or may not get that. Here are the running feet that are attached to the sockets. You can see that if you have a running foot, that there's no, well, you can see it's pretty much just one solid piece of metal. You got a socket stuck on top of a metal, basically a blade is what they call it. And those things are springy. Now, if you can think about this, see the guy, this guy is Oscar Pistorius, that was in the regular Olympics back in, I think, 2016. He always was a Paralympic gold medalist. He's from South Africa, and he fought his way to compete in the regular Olympics against regular track and field people. And for years they kept saying that he had an advantage over people because he had metal blades. Well, there's no way that an amputee is going to have any running advantage over a normal person. Nobody, but he could not get through that through the Olympic committee's heads. Finally, he won, and he competed in the Olympics 1 year. And he never came in last place. He never won any of his races, but all the meets he competed in, he never came in last place. And he's really known for that. Now he's known for being in jail for maybe shooting and killing his girlfriend, which we don't know if that's true or not, but that's what he's known for now. But there's all kinds of different feet out there on the market, just as many knees as there are on the market, just as different types of shoes as there are there. There's that many kind of feet for people to use. And they're all made out of carbon, so they're real lightweight and springy. And that would be it. So that's all for my portion. Let me turn the record.